case. It's a relatively easy one. 87-year-old woman presenting after trauma. Who would like to take this one? We've got lots of cases to go through, so if someone would volunteer, that'd be great. You can just shout out the what you see. Anyone? Anyone knows what this finding is? It's a Faucine subdural hematoma, right? So, when we're looking at trauma scans, we're carefully looking at the convexities for subdurals. But remember, subdurals you can also see along the falx and tentorium. So this case is just a quick reminder that we want to look in those areas as well for thin subdurals. All right, next case is a 70-year-old man who was hit by a car. And who wants to take this one? This is a challenging one because the finding is so symmetric. Anybody? I promise I will help you. What do y'all see here? So this is a challenging case that was missed by the attending and 2 residents that were reading this case because I think of how symmetric the finding was. So you can see there's symmetric widening at the C1, C2 joints bilaterally. So this is very worrisome for underlying ligamentous injuries and facet-capsular ruptures. So your next step, we use CT kind of as a screening test in the trauma setting. When we see any abnormalities that would suggest ligamentous injury or, instability, then we want to get an MRI of the cervical spine. So MRI cervical spine trauma protocol includes T2 space, so very thin T2 section to evaluate the ligaments. So here, this is your C1 lateral mass, this is your C2 lateral mass, and you can see there's abnormal widening that we saw on CT, and there's fluid in these spaces. That's worrisome for facet-capsular rupture. There's also fluid in the left atlanto-occipital joint, also concerning for facet-capsular rupture. And then at the cranial cervical junction, we want to look for our ligaments. So here, this is the alar ligament. So to find those, you find the odontoid process and you trace it towards the occipital condyle, and you can see there's abnormal fluid signal on the left side as well as on the right side, and so these are concerning for high-grade tears. This is just a normal for comparison, so this is your odontoid tip going towards the occipital condyle, so see how nice, thick and black this ligament is. So this is normal alar ligament on both sides, and you can see here now that there's abnormal tears, high-grade tears in this case. On sagittal, we can see even more injuries. So this is your tectorial membrane. There's also a high-grade tear of the tectorial membrane here. There's a lot of epidural hematoma surrounding the odontoid process. The AAOM, so the anterior atlantal occipital membrane, is also torn. And then you can see the cord is contused. There's abnormal T2 hyperintense cord signal here, and there's prevertebral edema and hemorrhage. This is axial T2, so we saw similar findings on the sagittal. There's epidural hematoma surrounding the dens, and then there's also high-grade tearing of your transverse ligament. So your transverse ligament and the alar ligaments that we talked about are the two major stabilizers at the cranial cervical junction. And then this is your contused cord with T2 hyperintense signal abnormality and some epidural hematoma. And then very important to recognize here is also you've lost your right vertebral artery flow void. So your vertebral artery goes through the transverse foramen, right? This left vertebral artery is normal, has a normal dark flow void. You've lost it on the right. And so this is high-grade vascular injury with right vertebral artery occlusion. So this would be a grade 4 Denver or Biffle vascular injury. That's confirmed on CTA. That was a lot. Does anybody have any questions? Okay, so cranial cervical junction injury, the atlantoaxial joint really relies on ligaments for stability. And like I mentioned, transverse ligament and alar ligaments are your major stabilizers. So you have to make sure you're looking at those very carefully. Atlanto-occipital dissociation has high mortality and morbidity due to brainstem, cord, and vascular injuries. And, our case really shows that coronal reformats on CT to look for cranial cervical junction alignment is very important, and we have to be careful of symmetric injuries. This is a companion case. It's a 44-year-old woman who was in a car accident. Does anybody see anything here that they worry about? So again, paying attention to the cranial cervical junction. This is a subtle case, but I was worried about how the right atlantal dental interval looks a little bit wider than the left. So when I see this finding on CTs, it could be two things. It could be maybe the patient's head is rotated. If that were the case, I want to see my C1, C2 lateral masses be perfectly aligned. But in this case, you can see like there's a little step off on the left side, right? Like the lateral edge of C1 lateral mass is not aligned with the lateral edge of the C2 lateral mass. So I recommended an MRI. And here you can see, so this is your odontoid process going towards your occipital condyle, and there's also high-grade tearing of the right alar ligament here. So remember, your CT coronal reformats are super important to look at your cranial cervical junction alignment. And when in doubt, get the MRI. Okay. Any questions before we move on? So the next case is a 34-year-old woman who presents with left-sided headaches and dizziness after exercising with squats and heavy lifts. Anybody see anything here? It's a MIP sagittal reformat of the common and ICA on the left. It looks pristine, right? It looks perfect. There's no abnormal narrowing that I can see on the sagittal. What about here? Anybody see anything? So here you can see kind of at the distal cervical petrous junction, there's abnormal narrowing of the left ICA compared to the right, right? And then in the petrous segment of the carotid, similar finding, there's asymmetric narrowing of the left petrous ICA compared to the right side, which is normal. So, this is a case of ICA dissection at the cervical petrous junction. So you have to remember that dissections, although most commonly happen just distal to the carotid bulb, they can originate at the petrous carotid. And it's a busy area of the skull base, so don't blow by it too quick, and remember to carefully look in that area. So spontaneous cranial cervical artery dissection causes up to 1 out of 4 strokes in young to middle-aged patients. 2/3 of them occur in the ICA, and like I said, most commonly originate 2 centimeter distal to the carotid bulb and terminates proximal to the petrous carotid canal. And less commonly, they can extend into the petrous canal and involve the cavernous ICA. About 1/3 of the dissections occur in the vertebral artery, especially the V2 and V3 segments. And remember satisfaction of search. Once you find one, keep looking, because up to 1/3 of patients can have multiple vessel dissections. This is a companion case. It's a traumatic ICA pseudoaneurysm, which would be a Denver Biffle grade 3 vascular injury at the cervical petrous junction. This is a young, I think 20-something-year-old lady who was in a car wreck. And so here you can see the left ICA is normal in caliber. The right ICA is pretty significantly narrowed. And then further up, more superiorly, there's this irregular outpouching posteriorly, kind of at that cervical petrous junction. And on the sagittal, you can see this irregular pseudoaneurysm much better here. All right, any questions about this case? All right, next one is a 58-year-old man who was found down. So I'll give you some time. Anyone who sees anything, feel free to speak up. So again, this is one of those symmetric findings. But in every case, in every CT, you want to make sure that you're seeing that, normal butterfly look of your basal ganglia and your thalamus, right? So usually you would have hypodense internal anterior and posterior limb of the internal capsule here, but we're losing that, right? The whole basal ganglia and thalamus bilaterally look hypodense and kind of edematous. And so on MRI, the T2 flare shows it much better, right? You've got diffuse T2 flare hyperintense ignore abnormality involving the bilateral basal ganglia and thalami. So I'm going to give you a few moments to think about what your differential diagnoses would be. So this case turned out to be ethylene glycol toxicity. There is no way that you would be able to come up with this diagnosis just based on imaging findings alone. They arrived at this diagnosis with some toxicology workup. But the teaching point in this case is I want you to know your top 3 differentials for basal ganglia and thalamic bilateral symmetric abnormalities. So the top 3 are going to be hypoxic ischemic injury, which in this patient's case, he didn't have that history. Toxic metabolic, so a lot of different toxic metabolic etiologies could have this appearance, ethylene glycol being one of them. Deep cerebral vein thrombosis can also give you this appearance. And then, other things to think about are encephalitis and CJD, as well as artery of Percheron infarct. But, this case would not fit the artery of Percheron infarct because the bilateral basal ganglia are also affected. If you only have bithalamic involvement, then artery of Percheron infarct would be kind of a good differential to have. So the reason, hypoxic ischemic and toxic metabolic injuries involve the basal ganglia is because basal ganglia has high metabolic activity. It's particularly vulnerable to systemic and generalized disease processes. So this is a companion case. It's an 18-year-old man who was shot at multiple places in the chest and abdomen and then had a traumatic arrest. And so here you can see, there's pretty prominent hypodensities involving bilateral lentiform nuclei. And then there's also diffuse cerebral edema. It's too crowded. There's, not enough sulci around. And then there's also hypodensities involving your bilateral occipital lobes. So this is an example of hypoxic ischemic injury. When you've got mild to moderate hypoxia, you can see watershed infarcts. But when you have severe hypoxic ischemic injury, you start seeing hypodensities involving your gray matter structures, like in our case, the basal ganglia. You can also see it in the thalami, the cortex, cerebellum, and hippocampi. On CT, you're looking for diffuse cerebral edema, diffuse cortical hypoattenuation, loss of gray-white differentiation, bilateral basal ganglia hypoattenuation, and that white cerebellum sign. The reason the cerebellum appears hyperdense or white is because you've got diffuse cerebral cortex hypoattenuation from the hypoxic ischemic injury. MRI is more sensitive, where you would look for diffusion restriction and T2 flare hyperintensity. Any questions about this case? All right, next case is a 78-year-old man who presents after motor vehicle accident. I'll give you some time to look at this set of images. So here you can see through the T12 vertebral body, there's a fracture through and through the vertebral body, right? So there's a fracture line here going through to the posterior cortex of the vertebral body. And then there's also involvement of the posterior elements bilaterally. So you can see the fracture line going through the pars interarticularis on both sides. And so you can see this is an unstable three-column spinal fracture, right? You're involving all three columns, and there's maybe a little bit of translation too. The inferior fracture fragments look a little bit posteriorly displaced relative to the anterior. So, what is the underlying condition that predisposed the patient to fracture? Notice how the superior thoracic spine, there's flowing osteophytes, essentially fusing this mid to lower thoracic spine, right? There's flowing osteophytes going all the way through. This patient has underlying DISH, so diffuse idiopathic skeletal hyperostosis. So in these patients, even with minor trauma, they're prone to fracture. And I've seen really bad three-column injuries just from ground level fall. Like essentially the spine is like a stick, kind of like ankylosing spondylitis, and with any minor trauma, they can easily fracture. So if I see a patient with DISH or ankylosing spondylitis and I don't definitely see a fracture on CT, I recommend an MR if the clinical team still has concern for underlying non-displaced spinal fracture. These can be very subtle on CT. In this case, no, because it's displaced, but non-displaced fractures can be very subtle and it's much easier to pick up on MRI. I'll give you some time to look at the soft tissue windows. There's a very important finding to pick up in addition to the fractures on soft tissue window. And if anybody sees it, please feel free to shout out. So focusing on the soft tissues in the spinal canal is where I want you to look. So there's a large dorsal epidural hematoma. So this line is actually your epidural fat, and there's hyperdense hemorrhage inside your dorsal epidural fat. And you can see like this is causing thecal sac narrowing, right? Especially at T12, there's a large amount of dorsal epidural hematoma, and it's most likely causing severe thecal sac narrowing. So this is your cord here, and this is that hypodensity is that epidural fat, and this is the hemorrhage. And you can see on sagittal, so this is at that level of T12 fracture, you can see there's dorsal epidural hematoma, so this thing, hyperdense. You've got a thin sliver of epidural fat separating the thecal sac from the dorsal epidural hematoma, and you can see it's tracking all the way up the thoracic spine. So it's very important to recognize and to tell the neurosurgeons, like, hey, there's a large dorsal epidural hematoma. They can correlate with, any neurologic symptoms and get an MRI if the patient is able to. So that's what we did. You can see the T12 fracture, T1 hypointense. There's also actually an L1 superior vertebral body fracture here. And so on T1, fat should be nice and bright and homogeneous. So this is your normal dorsal epidural fat up here in the mid-thoracic spine. And as you come down, it becomes very heterogeneous and dirty because all of this is hemorrhage in the dorsal epidural fat. This is T2. So you can also see T2 fat should be bright, and there's abnormal, heterogeneous T2 hypointense blood products in the epidural fat. And normal epidural fat would suppress on, this is T2 fat saturated sequence. So fat should be nice and dark here. But, the dorsal epidural fat, like here it's suppressed, but down here it's not. It's bright because of that large dorsal epidural hematoma. And you can see it's causing pretty severe thecal sac narrowing, and there's probably abnormal cord signal here. That's kind of difficult to tell because of how narrow the thecal sac is. So this is a T2 axial sequence. This is your dorsal epidural hematoma, this large T2 hypointense stuff. That's all hemorrhage. And this is your super narrow thecal sac, and you can see there's abnormal cord signal, where it's severely narrowed, and this is probably a combination of cord contusion and potentially edema from so much thecal sac narrowing. That was a lot. Let me know if y'all have any questions. It's a lot of imaging findings, but it's a lot of times it's not as easy to see the epidural hematoma on CT, but in this case, it is so, just so bad that you can actually see it very well on CT. So dorsal epidural hematoma is located between the periosteum and the thecal sac, and symptoms depend on the location of the hematoma and the degree of spinal cord and caudal equinal nerve root compression. It's important to recognize because it can be a surgical emergency. All right, if no one has any questions, we can move on to the next one. So this case is a 45-year-old man who presents with altered mental status and seizures. There's no significant past medical history. I'll give you some time to think about the underlying cause of the imaging finding, because the clue why this person hemorrhaged is on the image. Does anyone see anything? Any clue as to why this person has a large intraparenchymal hematoma? So here you see a large, intraparenchymal hematoma, lobar hemorrhage kind of centered in the left frontal lobe. There's some edema around it. The clue that I want you to notice is this superior sagittal sinus looks too hyperdense, right? Like compared to the posterior aspect of it, this looks pretty normal. This is too hyperdense. So, you want to look at your duodenal sinuses. That was worrisome for superior sagittal sinus thrombosis, right? And here you can see that clot in the superior sagittal sinus. It's not filling. The posterior aspect is filling okay, which is why that density posteriorly was normal on the non-con, but then along the rest of the superior sagittal sinus, there's an acute clot, right? Hyperdense on non-contrast CT and expanded and non-filling on the venogram. Your internal cerebral veins, vein of Galen and straight sinus are normally opacifying, but that superior sagittal sinus is not. So this is a superior sagittal sinus thrombosis. So when you have a lobar hemorrhage, these are kind of your top differentials you want to think about. So venous infarction, like in our case. So when you have a lobar hemorrhage, look carefully at the density of your duodenal sinuses. If it's hyperdense, recommend a venogram and pay careful attention on your subsequent CTA for any filling defects. And then in young patients, we also want to look for underlying vascular lesions. So CAV-MAL on MR, you wouldn't be able to see this on CTA, but AVM and dural AV fistula, you would want to look for on your CT angiogram. Hemorrhagic tumor or metastases, especially in patients with known history of malignancy. In patients with IV drug use history, you want to look for mycotic aneurysm. Look for that central dot sign in your hemorrhage, which could be mycotic aneurysm if it doesn't bloom on later phase imaging, or if it blooms, it could be an active bleed. And then in elderly, if you have lobar hemorrhage, you want to think about amyloid angiopathy. And on MRI, on susceptibly weighted imaging, you would see lobar predominant microhemorrhages with sparing of the deep gray. Or, because hypertension is so common, even though hypertension mostly affects the deep gray, if you have enough, it can also bleed within the lobar area. So on CTA, in addition to looking for underlying AVM, AVF, remember to look for that dot sign for potential mycotic aneurysm if there's relevant history and active bleed, as well as looking at your duodenal sinuses to look for venous thrombosis. Any questions? All right, next case. This is a 78-year-old woman who presents after ground level fall. This is a pretty straightforward one, so if anybody wants to shout out, it would be great. So yeah, there's abnormal hyperdensity and this collapsed appearance of the left globe, right? Ooh, sorry, I forgot that there's a chat box. Let me see. Oh gosh, I'm so sorry I missed this. Okay, I'm gonna put this over here so I can look at the chat box while I present. 1 second. Oops. Oh no, I'm so sorry I missed this all this time. Oh. Okay, one moment. I am having trouble. Sorry. I can't seem to get it to work on my other screen. Oh, there we go. Maybe.
Dr. Chien, if you want me to look at it and read it to you, I can do that too.
Oh yeah, that would be great. For some reason, I can't get it to I can't see
Yes,
the chat on my on
yes,
my.
I will keep looking on the chat box to
Okay,
see
awesome.
any question.
Okay,
Okay,
great. Thank you.
let's.
Thank you. Okay, back to my. Ah, okay, there we go. Okay, y'all can still see my screen, right? Okay, so
Yes, we have the screen.
you can see it.
Yes,
Okay, awesome. So, when I first, I missed this case when I was a resident. I did say that, there's abnormal contour and hyperdensity in the left globe. Um, but I miscalled it as thesis bulbi because I didn't see much periorbital trauma. So there wasn't much periorbital soft tissue swelling. There wasn't orbital fracture. However, I did not know to call thesis bulbi, you have to have ocular calcification or ossification. This is a case of open globe injury. The globe was not calcified. This hyperdensity was acute blood products in the vitreous. And so remember, to differentiate the two, look for ocular calcification or ossification. So thesis bulbi is a nonspecific sequelae of prior infection, inflammation, or trauma. So, open globe injury, blunt trauma to the globe can disrupt the sclera, resulting in globe rupture. Sclera is thinnest and usually tears just posterior to the extraocular muscle insertion. So, direct signs that we're looking for is altered globe contour and volume. And on MR, you can also see scleral discontinuity. Indirect signs, you can also look for altered anterior chamber depth. So this is an example of that. You've lost your normal anterior chamber. Normally, anterior chamber has some fluid in here, but here, like I've lost that, and the lens is halfway extruded through the anterior open globe. So this is a corneal rupture with that loss of anterior chamber depth and extrusion of the lens. Another indirect sign that you want to look for is intraocular foreign body or air. All right, any questions about this one? So next is, oh, did I hear something?
no, it seems like one of us got it right. Bulb rupture with vitreous hemorrhage.
Yeah, I just saw that. Great job.
Okay, all right.
Awesome.
We can move to the next one.
Sounds good. So next case is a 33-year-old woman who presents with fever and altered mental status. Per the family, the patient had been complaining of headaches and right ear pain. And importantly, there is no history of trauma. So what do y'all see here? And what would you be worried about? This is a challenging one, so I'll give you some time. And I have my chat open. Yes, for sure. Awesome. Somebody said there's pneumocephalus and air along the anterior middle cranial fossa. So the question is, why do you think there is air there? So the history is key here. There's fever, There is right ear pain and no history of trauma. There's another image for you. Like, why do you think the patient has pneumocephalus? There's something going on. Yeah, yeah. So there's abnormal erosion of the tegmen tympani. Absolutely. And why do you think? Why do you think there's erosion there? Right? There's abnormal middle ear and mastoid diffusion, and there's erosion of the tegmen in a patient with fever, ear pain. What would you be worried about? Otomastoiditis is an excellent thought, but the symptom onset is more acute. So we have to be careful. Chronic, I would expect, no fever, no altered mental status, and the bone, you could potentially see some periosteal thickening, but in the chronic setting, you should not see bony erosion. Anybody? This is a really challenging one. It was missed twice. So this finding, the pneumocephalus, the abnormal bony erosion, and middle ear mastoid effusions in the setting of fever, ear pain, I mean, this is very worrisome for complicated acute otomastoiditis, right? So coalescent otomastoiditis with probable intracranial um, extension, right? It's the air that you're seeing along the anterior middle cranial fossa, that's air from the middle ear and mastoid air cells. It's now directly communicating with the intracranial compartment. Any questions about that so far? Okay, so here we have the initial CT head. All right, so you can still see the basal cisterns, right? But then 6 hours later, like where are your basal cisterns? It's completely gone. So she's developed diffuse cerebral edema within 6 hours. So she's probably got meningitis from the complicated otomastoiditis, and she's developed edema from that. And then we got a CTA, and you can see there's actually a thrombus in the right transverse and sigmoid sinus. There's diffusion restriction kind of along the right cerebral hemisphere, and there's hemorrhage. So she's developed venous infarct with hemorrhage related to the durovenous sinus thrombosis. So this is all complications from her complicated otomastoiditis. And on this is T1 post contrast. You can see abnormal pachymeningeal and leptomeningeal enhancement. So compatible with that infectious meningitis. So this is acute complicated otomastoiditis. Intracranial manifestations, we want to look for adjacent durovenous sinus thrombosis, right? The transverse and sigmoid sinus run in close proximity to the middle ear and mastoid air cells, as well as venous infarction, which this lady unfortunately has. You can also see epidural abscess, subdural empyema, and leptomeningitis. In our case, we had leptomeningitis. You can also see cerebritis and cerebral abscess, particularly in the temporal lobe and cerebellum adjacent to that middle ear and mastoid air cells. You can also see suppurative labyrinthitis, petrous apicitis, which I showed a case of last year, and facial nerve palsy. Because remember, the facial nerve kind of runs in the labyrinth and temporal bone, so pathology there can knock out the facial nerve. That was a lot of findings. Any questions? It was a very challenging case. Okay, extracranial manifestations. So, the otomastoiditis can go intracranially, can also come out. So coalescent mastoiditis, you would see resorption of mastoid air cell trabeculae with the air cells coalescing into irregular cavity. Um, the pus can also perforate through the external mastoid cortex, break through the tip of the mastoid into the neck, and that's termed the bezold abscess, and that would form around the sternocleidomastoid muscle. Sometimes the abscess can also invade the external auditory canal and form anterior to the auricle. All right, next case. It's a 41-year-old man who presents with head trauma 2 to 3 weeks ago. This should be a pretty straightforward one. Anyone want to type out their answer in the chat? Yeah, awesome. Subdural hematoma, great. Subacute, awesome, awesome. So it's isodense to the adjacent brain. So this is just a quick case to remind us that we want to make sure the cortex touches the inner table in all of our cases. If it doesn't, look very carefully for underlying isodense subacute subdural hematoma. Great job. Okay, next case is a 29-year-old man who presents with dysphagia and hoarseness. This is also a pretty challenging one. What do y'all see here? Dysphagia and hoarseness. Anybody see anything? What's going on here? Oh, so the air in the prevertebral space, that's actually, it's just air in the aerodigestive tract. I will let that go. I want you to focus on this finding here. What do you think is going on there? So this is commonly mistaken for base of tongue mass, but it's not. So base of tongue mass, if it's a mass, it should enhance, right? But notice how the left tongue is just fatty, right? It's more hypodense compared to the right tongue. And this is actually ptosis of the tongue. So ptosis of the tongue from cranial nerve 12 palsy, right? So with loss of cranial nerve 12 innervation, the tongue becomes fatty and it kind of prolapses, becomes ptotic, falls backwards. So that's what it is. So left tongue ptosis here. What else do you see? Like, which cranial nerves in addition are affected here? Is my question. So you've got cranial nerve 12 with left tongue palsy, right? Left tongue ptosis, so cranial nerve 12 palsy. What other cranial nerves are affected here? Great, vagus nerve, awesome. So vagus nerve would cause vocal cord palsy, right? So the left vocal cord is out. Left vagus recurrent laryngeal nerve is out because um, you've got the sale sign here, so enlarged laryngeal ventricle and kind of fatty atrophy of that thyroid and arytenoid muscle. So this is concerning for left vagus nerve involvement. So cranial nerve 10. What about this one, the sternocleidomastoid muscle? Does anyone remember what cranial nerve innervates the sternocleidomastoid muscle? cranial nerve 11. So you've got cranial nerve 10, 11, and 12 palsy. Where do you expect the lesion to be? Like, where would you look along the patient's neck for a lesion that would knock out cranial nerve 10, 11, and 12? What space would you look for the lesion? This is a tough one. So remember, your cranial nerve 10, 11, 12 all run together in the suprahyoid carotid space. So cranial nerve 12 is going to exit out of the brainstem into the hypoglossal canal. 10 and 11 are going to exit and go into the jugular foramen, but then they join together in the suprahyoid carotid space. And so, look, like there is a dissecting pseudoaneurysm of the left ICA, kind of similar to that previous cases that I showed you at the cervical petrous junction. So this is the reason why he had cranial nerve 10, 11, and 12 palsy. It's because of that dissecting pseudoaneurysm. And interestingly, this patient had no known trauma or neck manipulation. The only risk factor that we could elicit was 10 years of hypertension. So, the teaching point here is when you look at this image, like, be careful. Don't call it a base of tongue mass. Like, look for that fatty, fatty atrophy of the tongue, and correlate with the physical exam. Like, this is tongue ptosis from cranial nerve 12 palsy. So important to differentiate from base of tongue mass, like I talked about, to avoid unnecessary biopsies. And tongue denervation has varying appearance depending on chronicity of the nerve insult. So MRI can be helpful during the subacute phase, where you can see edema and enhancement involving one side of the tongue. And then once you identify tongue ptosis, you want to follow the course of hypoglossal nerve to look for pathology anywhere from the medulla, hypoglossal canal, into the suprahyoid carotid space and sublingual space. Any questions about this one? Okay, next case, this is a 36-year-old man with HIV/AIDS, CD4 of 11, also has Burkitt's lymphoma of the groin, not anywhere in the intracranially. Polysubstance use, including methamphetamines, marijuana. He's presenting with lethargy, confusion, fever, bacteremia for pneumonia. So what are y'all seeing here? This is diffusion, this is ADC, this is T2 flare, this is also T2 flare. What do y'all think about this lesion here? And I should have shown you post-contrast. There is no enhancement. Anybody want to give a differential? Like anything that they think this could be? So there's questionable diffusion. Like it's bright on DWI, but not really dark on ADC. So very questionable. If there's diffusion restriction, maybe mild. So there's T2 flare hyperintensity kind of in the left cerebellum, but there's not much prior ischemic change at all in the supratentorial brain. Sorry, he's a bit motiony. Okay, well, 4.5 months later, the family said that he's getting more and more somnolent. And here you can see there's increased extent of T2 flare hyperintense signal abnormality, and there's kind of more volume loss involving the left cerebellum. It's not enhancing, and this time for sure it is not diffusion restricting. So I will tell you that this was initially called an ischemia, an infarct. But do you think it's an infarct? What other things would you consider here? Remember, this is an HIV/AIDS patient, CD4 of 11 only. Lymphoma is a good thought, but lymphoma should enhance, and it should have mass effect. And you would, in general, also see lymphoma restrict because lymphoma is so hypercellular, but that's definitely a thing you want to think about in an immunocompromised patient, especially because he already has lymphoma elsewhere in the body. So that's a great thought. What else would you think about? Infection, for sure. But what type of infection? Like there's a specific entity that you'd really want to bring up. This entity, yeah, perfect. Somebody said PML. Excellent, excellent. So PML, unless it's PML iris, it usually does not have enhancement, does not really have mass effect proportionate to the lesion volume. And so this is PML, perfect. And this has been described as the shrimp sign. So it's a shrimp-shaped lesion kind of in the cerebellar white matter, contacting but sparing the adjacent dentate nucleus. And I was reading this case out with the fellow, and the fellow was telling me, well, if it's PML, like, why would you have volume loss? If it's infection, why would you have volume loss? The thing is, like, volume loss can happen late in the PML course. So I think what happened was when he presented here 4.5 months prior, this lesion, I would have diffed it, right? Could be ischemia. However, in the absence of other ischemic changes in the brain in this immunocompromised patient, it could certainly be atypical infection such as PML. And at this point, he didn't have volume loss, but then as the disease progresses, he developed volume loss late in the PML course. So, PML, remember, like, classic distribution is that subcortical white matter involving the U fibers, but it can also affect the posterior fossa. So the teaching point here is you want to include other etiologies other than ischemia and infarct when there's a non-vascular distribution, when there's sparing of gray matter, and in our case, when there's an immunocompromised patient. I mean, the CD4 of 11, he's incredibly immunocompromised. And then also a patient with known history of malignancy, as well as young patients without vascular risk factors. So great job. Any questions about this one? Okay, next case is a 26-year-old man who presents after assault, hit in the nose with a glass bottle. And now he's presenting with right eye discharge. And on exam, there's copious green discharge from the medial aspect of the right eye. What do y'all see here? So there's obvious facial fractures, but I want you to focus on here. Like, what is going on here? Remember the history, copious eye discharge. Oops, sorry. It's here too. This is a interesting kind of, not a common case, but that history is really good for this. Copious eye discharge. Anyone? Medial canthus abscess. That's a really good thought. It's in that region, but there's a more specific thing that I'm looking for. Nasolacrimal sac duct injury. Perfect. Yes. So here you can see the fracture fragment is obstructing the nasal lacrimal duct, right? So here's your nasal lacrimal duct on the normal contralateral side. And here, the fracture fragment is obstructing that right nasal lacrimal duct. And so it's obstructed, and you've got dacryocystitis. So this is that obstructed lacrimal sac with associated inflammation while thickening. Excellent job. So this is dacryocystitis involving the nasal lacrimal duct, and it's just obstructed from the fracture fragment. Excellent, excellent. Okay, next case, 61-year-old woman with history of metastatic lung adenocarcinoma. Tell me what's going on 7 months later. Like, what is happening on this set of images? She has new headaches and altered mental status and history of metastatic lung cancer. Hydrocephalus, great. Do you think it's obstructive hydrocephalus or communicating hydrocephalus? Communicating, awesome. So the reason why it's communicating is because all of the ventricular system is dilated, right? Your lateral ventricles are dilated, your third ventricle is dilated, your fourth ventricle is dilated. So there's obstruction kind of at the level of arachnoid granulations and CSF absorption. So why do you think is causing her communicating hydrocephalus? I will tell you there's no ventricular hemorrhage. She is not presenting infectious. She's not febrile. Awesome, leptomeningeal metastases, great job. So yes, there's leptomeningeal carcinomatosis. You can see there's abnormal enhancement, kind of nodular, along the cerebellar folia, along your trigeminal nerve, so your cranial nerve 5. You can see abnormal enhancement along the IAC, so cranial nerve 7 and 8, as well as along your cranial nerve 3. And there's abnormal, leptomeningeal enhancement along the cerebral sulci as well. So great job. This is communicating hydrocephalus from leptomeningeal carcinomatosis. Other causes of communicating hydrocephalus you want to think about is subarachnoid hemorrhage, intraventricular hemorrhage, meningitis that we talked about, but she doesn't have either of those. And with that history of metastatic lung cancer, leptomeningeal carcinomatosis is the reason that's causing her communicating hydrocephalus. And in patients older than age 60, on average age 70 or above, you can think about normal pressure hydrocephalus too. But this is a diagnosis of exclusion. You have to exclude these 3 more common things. All right, any questions? Great job. Thank you all for participating. Our time is up. Please let me know if y'all have any questions.
That was so quick. It was fun.
Yeah, it's so much fun when people started participating. I super appreciate them.
Yes, I can see that. Okay. All right. If we have nothing else, have to thank Dr. Chien for sharing us with your expertise from Emory. Emory is a great place to be. It has a